I'll tell you why this happens, and the pain also causes a trigger and deep inside the throat as well. So because C2, C3 and the descending nucleus of fifth nerve, they communicate, and the pain in the deep throat and the facial pain, they unite together. So trigger can be reciprocal. If patient has got a pain in the occipital region, then pain can go into face or into the deep throat. And I have taken the video of the patient as well, that she says that the pain goes from here and goes up to here, so which is a classical C2, C3 distribution. One more thing that I would like to do, that she has got a pain which is spreading here, and there are some peripheral blocks which can be given even for a central neck pain, both in the upper limbs and lower limbs. So if I press between the fifth and the metatarsals here, then the pain radiates up to the neck. In this case, it's going up to the elbow. So I'm planning a deep block here, which will be diluted xylocaine, but it goes up to the dorsal root ganglion and can relieve the pain. I have several videos of such patients, so I'll be discussing them when I have my presentation. So right now, we will have a patient. I will do a left-sided greater occipital nerve block and a peripheral C6 block.
Is there anything to see on the imaging in this case?
Imaging, I do not find, because I had the films. I always prefer DICOM images on my laptop so that we can zoom them. Is there an axial for?
But
CT,
is there any thickening of the?
Yeah. So if you can see that C2 has got a thickening and the canal is severely low here.
Yes.
But this is not a bony window. Of course, there is a, but then suddenly here, it is a normal caliber. So,
yes.
And then here also, if you see, there is some lytic lesion going on. Patient says that this lesion has been there for many years and it is not changed with serial investigation. So, I don't know if the radionuclide scanning or something was done, because that's no record over here.
Okay.
Although, if such a patient with such a canal at C2, because C2 is one of the widest canals, why it is so tight here? And then I would also be questioning, as if I do a block, how long it's going to sustain, because when I'm doing primary migraine cases, I'm getting relief for up to 6 to 8 months. And we started in last year, when we started with auriculotemporal neuralgia. And since then, we have now done 93 cases of blocks, and I have got patients relief up to 1 year. So I could do only one surgery, because patients with nerve blocks are getting such wonderful results. But in such a case, first of all, I'm not finding that patient has got any long tract signs. She is able to walk.
Right.
So in this case, actually, she should be actually having a lot of ataxias. So those things are not happening. So I think more investigation should be done. And in such cases, first of all, if I have to evaluate, I want DICOM images on my laptop. I have my own Radiant software, and I go deep into that so that we can see in 3 axes as what's going on with this.
So your plan is.
So right now my plan.
Has she got any stigmata of CVJ? I mean, short neck or any?
No. She doesn't have.
Like
She has a long neck.
So sorry, your plan
Not
is.
really. So right now she only has got pain on left-sided greater occipital nerve pain. Severe neuralgia is there. So I'm doing a GON block on left side.
On the left side, sorry, you're doing a
greater occipital nerve
greater
block.
occipital nerve
block, and on left side I'm doing a C6 peripheral block. It has not been it has not been discussed.
Right,
but
right. The one you were saying in the anatomical snuff box.
Yeah, anatomical snuff.
Not anatomical, yes.
Yeah.
Yes.
So if you press here, the patient's got a C6 problem, the pain goes directly up to neck. In her case, it's going up to elbow. But this is variable. During my presentation, I will show you such cases where, if many times in severe cases, you press a patient at the sural nerve, and patient gets a pain all the way up to the neck. So whole spine pain can be there. So these are peripheral nerve blocks which are also used for central discs.
All right.
Yeah. And so I'll pause my mic for a while so that I can give instructions here.
Okay. We can have the OT view so that we know what's happening. Can you focus on the patient? Yes, sir. Greater, sir. Yes, sir. Ah, very easy, sir. We have done that. Those who haven't had not had the lunch, please have the lunch because we're running a little late. So we'll start as soon as this OT finishes. We'll start with the talks. ठीक है?